Good afternoon. Welcome to today's Grand Rounds. Please remember to sign the attendance records at the back of the auditorium, and also please remember to fill out the program evaluation, and please give us any ideas that you might have in regards to future topics or future speakers. Today, it's my pleasure to introduce Dr. Vanessa Curtis, who is a pediatric endocrinologist and currently clinical assistant professor at the University of Iowa in the Department of Pediatrics in the Division of Endocrinology and Pediatrics, and Dr. Thomas Scholz. Dr. Scholz is a pediatric cardiologist and a professor of pediatrics. They have kindly accepted the CME committee's invitation to come over from Iowa City today to give us a review of pediatric obesity, and please join me in welcoming Dr. Curtis and Dr. Scholz.
Is this on? Can people hear me okay? Great, thank you. Well, I very much appreciate the invitation to come here to Ames. It has been a number of years actually since I have been here. We used to come here on a regular basis to do pediatric cardiology outreach clinics back when I was a resident and fellow, and I was an avid bicyclist even back then, and always went to Michael's Cyclery. That was kind of one of my treats during the lunch hour. I don't know if they're still in business here or not, but I'd go and get a pair of socks or a jersey or something like that. But some very fond memories of coming into Ames, and the time spent here was really enjoyable. Dr. Curtis and I have started working together on childhood obesity and the complications from childhood obesity several years ago now. She started with one of my colleagues, and my colleague left to go to Colorado, and this wasn't something I initially had planned in my career path, but it was one of those things that everyone in the pediatric cardiology division looked around at one another and said, "You're going to do it, no, you're going to do it," and I guess I drew the short straw. I don't know, but I've really enjoyed working with Dr. Curtis, and I've learned a lot about pediatric obesity. But as you'll see, she's really the brains of the operation, and I'm kind of the guy she brings along to add some cardiology credibility in some of the things we talk about in clinic. And this is a little bit of a funny room from a question standpoint, but please, if there are questions as we go along, don't hesitate to raise your hand and shout out. I'd be happy to, myself, if I can't answer it, Dr. Curtis will, one of the two of us, and we'll certainly have time for questions at the end. And like many of these talks, I like to start off with a case study that came into one of our acute visits in our general pediatric acute care area at the university. And this was a 12-year-old female brought in because of asthma. And the family reported that the child had been having trouble breathing during exercise for the past 1 to 2 years. And in general, though, the patient was healthy, on no medications except PRN albuterol. Importantly, and this was important information to get during the initial visit, was that there was a family history of asthma, and the mother was overweight and was newly diagnosed with type 2 diabetes, and the father had an MI at 47 years of age, kind of a pretty suspicious family history. On the exam, the vitals, she was a little tachycardic at heart rate of 85. She was hypertensive at 134 over 67. She weighed 144 pounds at 61 inches tall, which gave her a BMI above the 95th percentile at 27 kilograms per meter squared. The rest of her exam was not too remarkable. From a heart standpoint, no murmurs, which I was always interested to identify or not. But she did have darkened skin along the posterior part of her neck and inner axilla, and some skin tags as well. She had previous labs that were done on a prior emergency room visit for asthma, where she had an elevated glucose to 156, but otherwise her BMP and CBC were normal. And a child like this coming in, you could probably do a pretty extensive workup and not find any cardiopulmonary problems in this child that would be contributing to her shortness of breath. There was no wheezing, and it had been going on for some time. And when you look at the profile of her labs as well as her size, she has a really horrible family history, with the dad having an MI at a fairly young age, a mother that is having problems with weight and has developed diabetes, And then she has signs in her own labs of metabolic syndrome, and we'll go into some of the features of metabolic syndrome later in the talk, but things like her blood pressure. This could be just related to anxiety related to the visit. But her glucose was certainly suspicious from her earlier visit. And all this is pointing toward the fact that obesity is a problem, and that you know some of these numbers, but they're really striking when you sit down and look at them, that 66% of adults and 33% of children are considered overweight or obese. And since 1980, the number of obese adults has more than doubled. And since 1970, obese adolescents have tripled. And since that same time in 1970, the number of obese children has quadrupled. And I'm sure for those of you in the audience who see kids, you've noticed this in your practice. And for those old guys like me, you think back in your childhood days and how seldom you saw kids who were overweight or obese, and how common that is nowadays. One of the consequences of that is that the current generation of children will probably not outlive their parents. And in an interesting study that was done looked at the health-related quality of life scores of obese children and adolescents, and found that they were lower than in kids with cancer who are receiving chemotherapy. It's a striking, debilitating process for many of these kids. And the economic costs are huge. 9% of the U.S. healthcare dollars are going toward treating complications of obesity. And importantly, from our perspective, is that the childhood obesity tracks into adulthood. So this is a little quiz question. What percent of Iowa children 10 to 17 years of age are overweight or obese? Any ideas? Anyone? Anyone do my favorite Ferris Bueller, an imitation of his science teacher? Anyone? 20 to 30 is right. Yeah, 28%. Whoever said that, I wish I had a prize. I was going to bring chocolate bars, but I thought that wouldn't work. I thought that would be a bad idea. But that was, as I was leaving, the only thing I had. But again, why worry about childhood and pediatric obesity? And it is a vicious cycle. The healthy child develops mild obesity, gets moderately obese, severely obese, and then is the obese adult. And there are actually some data to support that. When you look at the chance of being obese as an adult, it progressively increases as the kids get older. In that the infant, there's still hope. 14% of kids, if they're obese as an infant, will be obese adults. That percentage increases up to 90% for adolescents. So when you're seeing the adolescents in your clinic who are qualify as being obese, they're going to turn out to be obese adults more times than not. And this is one of the challenges we face in treating childhood obesity, is that the kind of path of least resistance is to end up obese. And it's a really difficult, we'll talk a little bit about some of the challenges with lifestyle and exercise changes, which are the only real opportunities we have at this point to intervene with the obese child. This is another kind of one of those board sort of questions that I don't know. I wasn't sure if there were going to be residents in here today or not, but I thought this is kind of one of those board questions that invariably shows up. Maybe if you've got to go through your accreditation test, this would be a question that would show up. But a child with a BMI at the 90th percentile for age and sex is considered, well, probably unlikely to make the cross-country team, I think is a possibility, but that child is considered overweight by the strict criteria that we'll go through in just a minute. So the BMI percentiles really do define weight status. It's a good screening tool. It's not perfect because there are changes in height, and you'll hear people talk about that, that they're going to go through a growth spurt, so it really doesn't mean that they're obese. But it is a good screening tool, and I'm sure most of you now, using electronic medical record, most have the opportunity to look at BMI plotted on one of the CDC BMI for age growth charts to get a percentile ranking. But it's important to look at that. And as the previous question pointed out, overweight is considered the 85th to the 95th percentile, whereas obesity is greater than or equal to the 95th percentile. we get this on many occasions. The BMI chart is wrong because they are just too short. As I say, a lot of parents say, well, my child's going to go through a growth spurt. It's not going to be an issue. But again, it's the conversations that we have with the patients that do point out that this is an issue is, I think, the way that we can actually start addressing some of these problems. And there is some room for hope and optimism, as this slide suggests, when particularly looking at the green line, you can see that the percent of kids who are obese over this approximately 10-year period has trended downward. So there is, you've probably heard on the radio news that there is a decreasing percentage of kids in this younger age range that are obese or have problems with their weight. The concerning curve, though, in my mind, is the 12 to 19-year-old, the purple curve, and that over the same period still is trending upward. And again, those are the kids who are going to have the greatest likelihood of going into adulthood obese, and this is where I think, again, the real problem is in intervening in these kids. And we don't have any magic bullets. I hope you weren't coming here thinking that we have the answer, but because we don't. And it's a real challenge for us in our clinic because we can talk about the importance of a good diet. We have the kids meet with their dietitians. We have them meet with our psychologists and maybe do an exercise study and talk about an exercise program for the kids. But it is a real change in lifestyle. It's a real change in how the standard operating procedure of that household has probably been going on. And it's something that I think begins with us recognizing that the kids are overweight or obese and commenting on that and suggesting opportunities for sugar-sweetened beverages, for increased activity, things that you can, simple suggestions that can be made when you see that there's a child coming into your clinic who is in the overweight or the obese category. I think there's pretty good information in the literature that commenting on that and making suggestions does move families in a direction that can provide some benefit. But the success rate is low, and Dr. Kurtz will talk a little bit about some of the things we do in our clinic to try to address some of the challenges with these kids. But I wanted to take I think that the societal movement is also helping us. And I wanted to take a brief moment to show a video that some of you may have seen. It came out from the Pediatric Healthcare Group in Atlanta. And it's a little disturbing, but I think and especially while you're eating lunch, and I apologize for that, but I think it's, again, where we're going to start to get some traction in the societal view of the challenges and problems of carrying and managing obesity. Now, let me see if I can change this over here.
All right, what do we got?
Just came in. Heart attack. 5'9", 300 pounds, 32 years old.
How the hell does that happen?
Can I get a, could be developing diabetes. To exchange. Oh, yeah.
You're graduating! Watch TV. You won't even have to leave.
You can't do this.
Yes, can I get a...
Yeah, no, deep dish.
You have to make a change. Good job, Jim. You got an A+.
There are your fries, sweetie.
I still can't believe you give this child French fries.
I know, but it's the only thing that'll make you stop.
So I apologize for that, if that is, but it is, let me just get down to where we're at here. But I think this is the sort of thing, it's a pretty striking video. It's raised a lot of, it just has been out only for a week or so. As I say, it was the Children's Healthcare in Atlanta that put it out. And it was kind of a bold move, I thought, because it really highlighted some of the things that we face day to day in the clinic that we have, that when we see a 4-year-old that weighs 90 pounds, the challenge is not with the 4-year-old, and it's trying to convey that message that it isn't the child's fault that they're overweight. And so it's a struggle. It's a difficult conversation. We've had families in tears in our office when they hear that there are things that they are probably not doing exactly as they should in raising and feeding their kids, because it's a very sensitive issue. But I think we're making progress. I think that there's a little bit of a sea trend that's changing out there, and we are again, I think, not there with magic bullets, and that's the first thing that we talk about with our families. One of the things that we do in the clinic, though, is we do look for complications associated with diabetes, because that is something that we can treat. And certainly our first attempts are not to give medicines, but there are complications and comorbidities associated with the overweight and obese child that our clinic spends a lot of time working on. And I wanted to go into a little bit about that just from the lipid screening standpoint, and then turn the podium over to Dr. Curtis to talk a little bit about some of the other things we screen for in our clinic. And why would we want to do pediatric lipid screening? And there's some pretty good data to support that the childhood cholesterol levels are predictive of adult levels. The Bogalusa heart study from down in Louisiana identified that 70% of children with elevated cholesterol have elevated cholesterol as a young adult. And the Muscatine, Iowa, from studies that Dr. Lauer had pioneered, my boss who had hired me to come back to Iowa 20-some years ago, really did an amazing job with tracking the families in Muscatine, and found that if you looked at the percentile level, 75% of the children who had cholesterol levels above the 90th percentile are going to have elevated cholesterols above 200 in their early 20s. So it's important to identify those kids and intervene, if possible, without medicines. But if medicines are needed, there are good medicine alternatives that can help slow the progression of atherosclerosis. And we do know that atherosclerosis is a progressive disease. This slide kind of just demonstrates in the cartoon type fashion the progression from a normal vessel through the fatty streak, the early atheroma, stabilized plaque, and vulnerable plaque. And when they've looked at autopsy studies, the prevalence of these various lesions is quite high. The initial thing of the fatty streaks in the vessels is found in more than half of the kids who, these are usually kids that have died from trauma and have careful autopsy studies done. But the remarkable thing is that 4% of those kids already in the pediatric age range are developing vulnerable plaques. And some of these studies go back quite a ways, and I suspect if we were looking now, we would find higher percentages of vulnerable plaque in the kids. The other aspect of lipid screening that's important is that there are an important percentage of children and adolescents that have elevated lipid levels. And this has been shown in a couple different trials. The child and adolescent trial for cardiovascular health looked at over 5,000 third graders, and found that 13% of them had a cholesterol greater than 200. The National Health and Nutrition Examination Survey found that 10% of adolescents had a total cholesterol over 200, and that number increased to more than 20% having a lipid abnormality for a later time period. So the prevalence, just like with obesity, is increasing. So the screening guidelines, these are the official screening guidelines that were put out by the NIH and endorsed by the American Pediatric Association, or the American Academy of Pediatrics, rather. And their screening guidelines are that in the kids 1 to 9 years of age, no routine lipid screening is needed unless there is a positive family history or the child has other risk factors, like some of our kids that have high levels of obesity. But in 9 to 11 years, universal screening is recommended. I'm not sure how many people do that. In the audience, I mean, people seeing pediatric patients, I'm not sure that this has really been well accepted, and I think even among our pediatricians at the university, this is not universally done. I think that they mainly look at kids who have risk factors, if their kids are obese or overweight, or they've got a strong family history, and certainly those would be the kids you certainly want to be doing lipid screening in. But there have been kids without a family history who have been referred to our clinic who had on screening have had identified elevated levels of one lipid component or another. 12 to 17 years, no lipid screening is suggested based on these guidelines unless there's a change in family history or the child has developed some risk factors. And then universal screening again around the time the kids start going to college is also recommended. And what should be ordered for the lipid screening? Ideally, you'd order a fasting lipid profile that would have the triglycerides and LDL measurement done following an 8 to 12 hour fast. If non-fasting lipids, sometimes kids come in to your office and you know it's going to be difficult to get them back. A non-fasting lipid profiles can be used. And that gives a pretty accurate measure of non-HDL cholesterol, but the triglycerides and LDL will not be reliable. And children, just for completeness sake, children should be on their regular diet for 4 to 6 weeks before lipid testing to assess the true lipid status. If they've had severe illness in the last 4 to 6 weeks, you should delay the testing. So those are kind of a couple little provisos to it. But certainly, if there's a challenge in getting the kids back, getting the values, even if they're non-fasting, is important. And before I turn over the quiz, before we go into this quiz, I'll turn this over to Dr. Curtis and we'll let her take on from here.
Can you hear me okay? Okay. So thank you also for having me. This is actually my first real trip to Ames, so it's exciting. So I'll start right off with a quiz. So all of the following are components of the metabolic syndrome except elevated blood pressure, high triglycerides, obese BMI, high LDL, fasting glucose over 100. Let you think about that for a second. So actually, the high LDL. So we'll talk a little bit about the metabolic syndrome. So as you might remember, I think most of you are pediatric providers, but we all learned about the metabolic syndrome, which really only has a true definition in adults. But we do see this same pattern and same spectrum of conditions in pediatrics. And really kind of the central feature is this obesity and typically the high risk, more central adiposity. And then, the cutoffs we use might vary depending on the organization creating the definition, but essentially central adiposity, some degree of insulin resistance, which underlies probably the rest of the components, including high triglycerides, low HDL, high blood pressure, and some form of impaired glycemic control. And again, we don't really have a strict label for a pediatric metabolic syndrome, but mostly because they're growing children, we need a lot of different criteria, but we do see this pattern. So with that in mind, recommended screening tests for sequela of obesity in pediatric patients include all except blood pressure, lipid panel, glucose, ALT, insulin. Let's think about that. So insulin. So let's talk about glycemic control, because that's sort of, as the endocrinologist, that's sort of my big focus. So contrary to what the lay press would have you believe, type 2 diabetes in our pediatric population is actually pretty rare. We don't see a lot of it. We do see some of it. But what we see a lot of is insulin resistance. So I like to, when I talk to families, I kind of like to talk about, there's type 2 diabetes. And I feel like a lot of times when families come, they're really worried about that. And I usually can be pretty reassuring and say, yes, your child does not have diabetes. But there's a spectrum. And on one end of the spectrum, we have the lean, healthy, active kid without a family history of diabetes who has a low risk of having diabetes in their lifetime. And on the other end of the spectrum, we have the kid with type 2 diabetes. But there's a big spectrum in between, and most of the patients we get in our clinic are somewhere along that spectrum. So kind of the way I describe it to the families is when you have some risk factors, including a family history of diabetes, increased adipose tissue and decreased lean body mass, sedentary activities, all those things kind of combine together to make that body insulin resistant. So then when that child is eating food, which includes carbohydrates, their pancreas has to make extra insulin to achieve normal glycemic control. And that's all fine and good until the pancreas cannot keep up with that. And so what we tend to see in the early forms of this insulin resistance are normal fasting blood sugar, normal 2-hour postprandial blood sugar, but high insulin levels. And over time, as that child becomes more insulin resistant, and eventually as their beta cells start to fail, then we start seeing impaired glucose control. So first we would see an impaired glucose tolerance, so either on a 2-hour OGTT or really just a postprandial glucoses we start to see creeping up, and then ultimately start seeing impaired fasting glucose, and then there's some intermediate cutoff ranges, and then we see type 2 diabetes. So most of the kids we see are somewhere in this range, but with quite high insulin levels, and so it's only so that puts them at high risk. So why do we care so much about catching the kids before they get diabetes? It's because type 2 diabetes in our pediatric patients is very hard to treat. This was kind of the biggest prospective study of type 2 diabetics. This was 10 to 17-year-olds that were recently diagnosed with type 2 diabetes that were followed prospectively. And what we see is that children at a 5-year range have about a 50% failure rate on oral medications and the need to go to insulin. You might say, well, look, this metformin-rosiglitazone combo looks pretty good, but actually rosiglitazone is really kind of off the table because it has some cardiovascular side effects. So really with our pediatric patients, if they do get diabetes, we're pretty much just left with metformin, and if that fails, we have insulin and all the negative things that go along with that, including weight gain, hypoglycemia, need for blood sugar monitoring. So really we'd like to catch the kids before they get to type 2 diabetes, and if there's any way to reverse that trend, do it. Now, what about, do we have to wait till kids? So I've added this metformin stuff in because I feel like this is what comes up a lot when people ask me questions, so I hope it's not too much metformin. But so we have metformin. It's our first line medication for adults and pediatrics with type 2 diabetes. It's an old medication. It was developed in the 50s. It's very safe. So what about using it for diabetes prevention? What about using it when that child just starts getting into that spectrum? And so that is something that's been studied, and we're doing a fair amount. This is a real kind of an older study, but it's one of the first ones to really look at the use of metformin in these high-risk people. Now, this is an adult study, but this was a large 3,000-person multi-center study that looked at using metformin to help prevent the progression of diabetes in people who already had either an impaired fasting glucose or impaired glucose tolerance. And they did see that compared to placebo, metformin reduced the incidence of diabetes over a 4-year period by about 30%. Now, you will see here that it's not as good as the lifestyle arm, and this lifestyle arm was pretty traditional guidelines, like exercise 150 minutes a day, reduce your body weight by 7% by cutting down calories a little bit. The thing that they had in that arm was they had like a life coach kind of person helping them with it. So essentially it shows if you can achieve those lifestyle measures, that's the best. But the metformin did have some benefits. So I do have a fairly low threshold in those kids that are progressing into that pre-diabetic state to use metformin. But we kind of an individualized thing until they actually get diabetes. Now, what about using metformin as a weight loss drug? Because we do find that it is one of the side effects of metformin for some children that they do have some weight loss. And so this is something that's been people are very interested in because we don't really have other safe and effective drugs, particularly in the pediatric population for weight loss. It is not marketed as such, but it is being used off-label for that reason. So there was just recently a really nice big meta-analysis of studies in pediatrics, non-diabetic kids who are obese and looking at weight loss. And what they did find when you look at they took the best, most high-quality randomized controlled trials, is that metformin used at 1,000 to 2,000 milligrams a day did result in a statistically significant reduction in BMI by about a point in the short term. Most of the studies were around 6 months. There were a few that went up to a year. Some of them are a little shorter. you could argue is a BMI going from 30 to 29, is that clinically significant? It may be. So, but it's small, I guess is the point. So I don't like to say that metformin is a weight loss drug, but it can be helpful for weight loss in some situations. One interesting thing that some of these smaller studies started to find that there may be subgroups of kids that actually respond better. And I think I anecdotally feel the same. They found girls, more obese girls, people who are of Hispanic origin tended to respond a little better. So we'll have to see as more research comes out. There may be more of a role for metformin in this role or in this setting. I tend to use it in the kids who are at high risk of diabetes. If it's another option we use, again, individualized though. Okay, that's enough with the insulin. A couple other things we screen for in our clinic, non-alcoholic fatty liver disease certainly is a big problem. We kind of went back and forth when we were starting the clinic. Do we even screen for it because there's no treatment? But we do measure an AST and ALT. And fatty liver disease is one of those things where it's not so much about the actual weight, but the rate of weight gain. So the kids that are gaining a lot of weight real quickly, there's definitely a genetic component, but as they have that weight gain and that insulin resistance develops, the fat accumulates in the liver, and then in some of the kids that causes some steatohepatitis, which can go on to cause liver failure. And it actually is, and I've seen this projection by in several settings where the indication for liver transplant by 2020 is the most common indication is going to be probably fatty liver disease. So it's definitely a problem. There is no treatment other than weight loss, but it's nice to identify it. If we identify high liver enzymes in our patients, we give them a trial, we work on weight loss. If their liver enzymes still stay more than twice the upper limit of normal, we do have them see our GI colleagues just to make sure there isn't something else going on, some other hepatitis or inborn error metabolism that would cause that. But then if we've confirmed that's true, then we just focus on weight loss. Hypertension, another common comorbidity of the weight gain, and certainly probably underdiagnosed and underrecognized in some levels. When we see obese kids with high blood pressures, we first have to think of them as just kids with high blood pressure, so we need to consider all of the causes of high blood pressure. So are they just nervous? Nobody really wants to come to our clinic, so the kids are usually not happy about being there. So we do check again. Our MA is super at giving them time to relax and recheck it. We do consider other causes of hypertension too. Do we need to get an echo and look at the aorta? Do we need to consider renal disease? And then we also, if necessary to get more data, we'll have them go to the school nurse or go back to their primary clinic and get more data. Ultimately, if we're thinking a child needs to be treated, we at our institution have them see nephrology to complete the renal workup and initiate therapy, usually with an ACE inhibitor, sometimes a calcium channel blocker, and then we kind of resume care from there. So we take it seriously and let the nephrologist start the therapy in the under 18 set. And then, we do, the problem with obesity is, as it affects all of the organ systems, and not the least of which is some of the psychologic and then also musculoskeletal. So we do screen and refer as necessary. We are lucky to have a psychology intern in our clinic right now who is really interested in behavioral change and also really good at identifying kids who need more advanced psychological support. So that's helpful. So kind of what Dr. Scholz was already kind of alluding to, as you guys already know, treating kids with obesity is really hard, especially when we're treating the obesity and not just the comorbidities, because first of all, kids aren't controlling their environment. They're really put in their environment that's provided by their family and their school to some degree. And so we're really trying to focus on this as a whole family intervention, because as I always tell parents, you can't expect a 10-year-old to come home from school and rummage through the fridge to find that one apple in the back when there's a bag of chips sitting on the counter. So we really need to set them up for success. The other thing is the kids that are still growing, or even the kids that aren't growing but who have been gaining weight quickly, we really start with weight maintenance as our goal usually, because a lot of times the kids do still have time to grow into their weight. And of course, as you know, there are a lot of barriers to having all these discussions, including families' acceptance of it, families' readiness and comfort to talk about it, your own comfort level to talk about it. I find For us, it's a little easier sometimes because the subject has already been broached by the referring provider, so we don't have to have that initial elephant in the room discussion, but it can be hard, especially when the whole family is struggling with the same things. And some families are ready and some families aren't. So back to the patient that Dr. Scholz presented at the beginning, I think in an ideal situation, even in an acute visit, identifying a child that has high blood pressure and abnormal glucose, signs of insulin resistance, of obese BMI, ideally, even though she's not there for that, that is identified and, well, in a perfect world, even addressed. But even just identifying it and making a comment is the first start, again, in moving people down that pathway. As you know, most of these kids don't see other providers. They see their pediatric provider when they come for their health supervision visit and their sports physicals. And so identifying early on that abnormal weight gain, plotting the BMI, because we do kind of get a little bit numb to, you see kids that are big and they look okay, but then if you plot it, it's not so good. And looking for these complications related to obesity. The other thing I've found, being on the getting referrals, is a lot of families they remember, even if their primary care provider just said them something little, like cut down the juice or take your kid to the park, they too take that to heart, a lot of them. And so even if you feel like you don't have a lot of time, you don't have a lot of resources, just that initial identification and a couple tips, I think do go a long way, because most of these families do put a lot of stock into what their providers say. So just getting to our clinic, when we accept referrals from anybody for really, for these kids that are developing sequela of obesity or you're really worried about, we have a clinic that we see kids on Mondays at our Iowa River Landing Clinic. And what we do is if we get the referral ahead of time, we'll send them a diet log so they can do a 3-day diet history leading up to the visit. They can fill out some family history that really prompts them to think about who in the family has high cholesterol, who in the family has had heart attacks. The kids who haven't had labs done by their primary, they get them right when they get there so that their results are ready by the time we talk to them. And then we kind of divvy them up. Sometimes they see cardiology and endocrine. Sometimes they just need more one than the other. Sometimes they can really only handle one. and then we use our psychology intern who's really helpful at helping kids with setting goals and helping parents kind of like, how are you going to help your child achieve these goals? What sort of reward system can we work up? How can you use some good parenting skills to help support your child? And then for the kids who would benefit, we have a nutritionist, like formal nutrition consultations. But I think what we try to do that makes our clinic kind of, I think, special is that we try to do this all together, giving a central message so they're not hearing a lot of contradictory or too many things. So we try to identify, is there any medications needed? Are there any like 1 or 2 activity goals, 1 or 2 diet goals, and try to support them in that. So this is just a little bit more about our clinic. There's free parking, which is probably the biggest plus. I think parents, if they've come to any other University of Iowa clinic, they like that part. So we're happy to take any consults, and if you have questions about kids, we're always happy to do that by phone or email too. So, all right, I think that's everything. So if there's questions.
Yes, in the back. Oh. Across continents?
Japan, Western Europe. What about other nations besides the United States? Is that trend still follow there too?
Yes is the short answer. I think it depends on the country. There are some countries that are actually experiencing a more rapid weight gain. They're kind of behind us. They're experiencing what we experienced in the last decade, like some of the Middle Eastern countries. But it's a pretty universal phenomenon.
And it is worse in some of the developing countries as their diet gets improved and westernized, if you will. What had been less developed countries with food shortages, now if there are better access to foods and transportation, they tend to follow this trend. So yeah, it's a global problem, and I think some countries are doing better to work at it than others, for sure. Yes.
Yeah, just an interview I heard on NPR a couple years ago. Thought was kind of interesting, and maybe you can shed a little light on it. I really don't expect a detailed answer, but this, I suspect, was physician. His understanding and his biases were that our ancestors, many thousand years ago, were always programmed to eat every time food was accessible, because it rarely was accessible. And so we have genetically inherited, for lack of better words, that programming that every time food is available to us, we'll eat. And obviously today there's food everywhere. I mean, does this, again, I don't expect a very detailed answer, but does this make much sense to you?
So I'll start with that because I think that is so true. Not only are we genetically programmed to seek food when we can have it, but we have evolved, our many, many generations of humans evolved in a time of nutrient scarcity and high energy output. So if you think about the hunter-gatherer lifestyle, it was days and days of constant activity and then feasting. And so we are genetically evolved to not be in the environment we're in. And actually, sometimes when families are really upset and they're like, what is wrong with my child? I sometimes even say, your child would be, so superiorly evolved to be in the setting that they were meant to be in. But right now, it's the setting that is wrong. And so we can't change our genes that quickly. I mean, give us a few more generations, I guess. But what we need to do is try to change the environment to more closely mimic what we're meant to live in. So not having food sitting around, walking to school, not sitting and watching TV all the time. That's the problem. It's the environment, not our bodies.
And I also think, though, that in the busier lifestyle that people have nowadays, and we hear this a lot, where the mom will say, well, I work all day, and maybe it's a single mom, and she's trying to figure out, she picks up her kids at the daycare where they have she may not have much control at the daycare of what her kids are getting. But she gets home at 7 o'clock, and then she's going to try to figure out what to make for dinner, and it's easier just to zap something from the freezer section. And one of the things we talk about with our family is that you can, within minutes, take in enough calories that you'll have to exercise for hours to get rid of. And there's so many things that you can get in the grocery store nowadays that, again, in moments time of eating, you can have hours worth of exercise that you need to do. And one of the things we also talk with them about is just thinking about when they go shopping. Hy-Vee has a great program that they have dietitians at many of their stores. They can go around with the families and talk with them about proper choices. But a lot of the walking around the dietitians do is around the perimeter of the grocery store. And so just making that one suggestion to families really lights a light bulb in many of them to say, do most of your shopping around the perimeter and not in those middle aisles where they're the high calorie and high carbohydrate items, around the perimeter where you can get your fruits and vegetables, where you can get your meats and things that you need to cook, but things that are going to be better for you in general.
Yeah, two questions. What percentage of physicians are obese? And the second question is, what's the physiological connection between asthma and obesity?
I don't know the answer to the first one. And
I have seen some studies on this, and it's lower than the average population. It's actually one of the lowest professions, but I don't know what the percentage was. And the asthma obesity connection.
Yeah, I don't know the answer to that either. I think that the growing prevalence of asthma in the pediatric population, whether that's just incidental or not, I don't know the answer to that. I don't know that I've never seen a study on that that I'm aware of.
I do think that there's some asthma that's just deconditioning that nobody really delves into, whether it's the family or the family doctor or the ER, that just they get that label and the kid gets short of breath with exercise, so the family just assumes it's asthma. But I do think there is some connection. I have seen a little bit about that, but I don't know any more about it.
And a lot of times we'll get the parents saying they're limiting their kid because they turn all red in the face and they get they're breathing super hard and it Yeah, it is, but they're from a cardiovascular standpoint. That's again one of the things I can talk about to the families, and perhaps they think because I'm a cardiologist I have some credibility to say so, but to say that from a cardiovascular standpoint they're not going to be damaging their heart or their lungs by continuing that exercise if they're a little red in the face and breathing hard. So, but that doesn't exactly answer the question. It just kind of talks around it a little bit.
How do you address the cost of healthy food? I try to eat salads, and I spend 5-6 times as much as if I eat something unhealthy. And I can afford that, but not everybody can.
We get that a lot in clinic, and it is a little bit of a challenge. There are some healthier options, some of the stir fries and things like that. You can get things on sale. A lot of times we'll talk to families about going to Costco or Sam's Club or Aldi's. A lot of times Aldi's will have sales on things that are really quite substantial. And it's good stuff. I mean, it's really good produce. And the other thing we just found out the other day, someone was telling, I don't know if you were in clinic, but they were saying that with the Aldi's ad, Fairway matches the price in the Aldi's ad, so they can go shopping at Fairway with an Aldi's ad and get the lower price. So there are ways and mechanisms of doing it, of getting the healthy items. It may take a little bit more of a effort, and certainly the cooking part of it really is sometimes a problem too, because a lot of times you get the families that no one in the family knows exactly how to prepare some of these things, and so I always pass out my favorite cauliflower recipe that just roasted cauliflower with a little bit of olive oil with some salt and pepper. You roast it for half an hour, and it turns out like candy. And I get maybe half of them to come back and say, yeah, it's kind of candy, But making some of those suggestions, again, it takes time. But again, some of these things that just get the people, get our patients thinking, the families thinking about how to work with those items that they can get in the produce lane. Well, again, thank you very much for inviting us. This is great.